Hey everyone, welcome back. Rachel, how's it going today?
It's going great. I'm super excited to be here.
All right, let's kick things off with the absolute basics. When we're talking cardiac auscultation, where do we even begin to listen for the heart valves?
Great question. We've got four main spots. For the aortic valve, you're at the second right intercostal space, right next to the sternum.
Okay, so right side for aortic and pulmonic is opposite, I'm guessing?
Exactly. Second left intercostal space, left sternal border. Then tricuspid is lower left sternal border.
And mitral, the famous one.
That's at the apex, fifth intercostal space, mid-clavicular line. Think of it as directly under the nipple, roughly.
Got it. So once we know where to listen, how do we tell if a murmur means stenosis or regurgitation? Is there a trick to the timing?
Absolutely. There's a key principle. Stenosis murmurs happen when the valve should be opening.
So it's struggling to open.
Right. And regurgitation murmurs happen when the valve should be closed, but it's leaking.
So aortic stenosis thought it'd be a systolic murmur because the aortic valve opens during systole.
You got it. And aortic regurgitation would be diastolic, since it should be closed then. It's really intuitive once you get it.
That's so helpful. So basically, if a valve is supposed to be open and it's making noise, it's stenosis. If it's supposed to be closed and it's making noise, it's regurgitation.
Precisely. That's the fundamental logic of murmur timing.
Stenosis grows stiff and hardened, opens only just a thread. Blood must strain with rising pressure. Burdened pathways lie ahead. Walls grow thick from constant labor. Strength that bends toward breaking soon. This is not the heart made healthy. This is not the maker's tune. Regurgitation swings loose and failing, cannot seal the backward flow. Blood returns where it should not be, circles where it ought not go. Chambers stretch like tired canvas, volume swelling past design. This is not the heart made ordered. This is not the holy line. The healthy gate stands firm and faithful, opens wide and closes true. Forward flow in perfect cadence, strength and rest in balanced view. Pressure steady, volume gentle, every beat in harmony. This is how the heart was crafted. This is how it's meant to be. There are gates that strain and falter. There are gates that leak and fail. But one stands pure, unbroken, steadfast. One true path on which we sail. For the heart has many chambers, but the soul has only one. There is one way to the Father close, and that way is Christ the Son. Not the narrowness of stenosis, not the looseness of the leak, but the strong and living doorway, where the lost find what they seek. Three kinds stenosis, tight regurgitation leaky. But Christ the gate stands perfectly. Pressure burdens in stenosis, volume burdens in the leak. But the healthy valve moves freely, strong yet gentle, never weak. So the heart reveals a mystery written deep in flesh and bone.
So when the ventricles squeeze, the valves themselves have to open. During systole, the ventricles would be squeezing, but in the valves during systole, the valves themselves will be opening. That's why there's stenosis during systole in the aorta. Regurgitation happens during diastolic because in the aorta would be closing while the ventricles are relaxing to fill up with more blood.
Okay, so we've talked about the general auscultation sites. Let's really narrow in on the mitral valve because that's super common, right?
Absolutely. The mitral valve is a huge one. First up, mitral stenosis.
Stenosis, so the valve isn't opening properly.
Exactly. This causes a diastolic rumble and often a loud S1 with an opening snap.
A rumble and a snap sounds dramatic.
It can be and often leads to AFib.
And regurgitation, that's when it doesn't close all the way, right?
Yes, that's a hollow systolic murmur. You hear it throughout systole. It can lead to pulmonary congestion.
Because the blood backs up?
Precisely. And then there's mitral valve prolapse, MVP.
Oh, like a click that I've heard about?
Yes, a mid-systolic click, sometimes followed by a late systolic murmur if regurgitation develops.
So what causes these valve problems in the first place?
Age-related degeneration is actually the most common, but also things like hypertension, endocarditis, and rheumatic fever.
Rheumatic fever, is that still a thing?
Unfortunately, yes, and it typically damages the mitral valve.
So after all that, sometimes a valve just needs to be replaced, right?
Yep, and there are two main types, biological and mechanical.
What's the difference?
Biological valves are from animal tissue, good for about 10 years. Mechanical are synthetic, practically forever.
So mechanical is better then.
Not always. Mechanical valves require lifelong anticoagulation, like warfarin.
Oh, so blood thinners forever.
Exactly. And warfarin is teratogenic, meaning it's bad during pregnancy.
So for a young woman, a biological valve might be better, even if it means another surgery later?
Absolutely. It lets them have kids without warfarin risks.
What about TAVR? I hear about that a lot now.
TAVR is transcatheter aortic valve replacement. It's for the aortic valve only, originally for high-risk patients.
No surgery? That sounds great.
It is. Its durability is proving to be around 10 years, making it more widely used now.
So it's less invasive, but maybe not forever.
Precisely. The future might even see transcatheter mitral valves, but that's still being researched.
Okay, so we've talked about all these mechanical things with valves, but what about the heart's electrical system? How do we read an EKG?
That's crucial. First, find the dominant rhythm. Don't get sidetracked by a single weird beat.
So, like, what's a first-degree AV block?
PR interval over 200 milliseconds, but constant. Often benign, just check for drug effects.
What about the big ones, like AFib?
Irregularly irregular. No discrete P waves. If unstable, immediate cardioversion is needed.
And VTAC, that's serious, right?
Definitely. 3 or more PVCs in a row. YQRS. It's life-threatening.
PVC is those extra beats?
Right. No preceding P wave, wide QRS. 6 or fewer a minute, usually okay. More than that, or if they form patterns like triplets, you start worrying.
So if someone's drinking a lot of energy drinks...
Exactly. It's a common cause of those extra beats. Electrolytes, too.
So moving from the electrical side to the plumbing, let's talk about hemodynamic monitoring. What are the core concepts here?
Well, it's all about pressure and flow, right? How much stuff is in the space and how well it's moving.
Stuff in space, so like blood volume and how much force it's exerting?
Precisely. And then there's preload, which is how much the heart muscle stretches before it pumps.
More stretch equals a better pump, up to a point, right?
Yes, the Frank-Starling law. Then, afterload, the resistance the heart has to push against. And contractility is the actual squeeze.
Okay, so preload, afterload, contractility all feed into cardiac output?
Absolutely. Cardiac output is stroke volume times heart rate. It's the big picture of how well the heart is delivering blood.
And chronotropy is just about heart rate?
Exactly. It's the time aspect. These concepts are vital for understanding if someone's hemodynamically stable or not.
So are they getting enough oxygen to their tissues?
That's the ultimate goal of monitoring it all, keeping the demand-supply in balance.
So how does all this get measured? What's actually in a hemodynamic monitoring system?
It's pretty cool, actually. Think of it like a drum. You have a fluid bag, usually saline. That's your stuff.
Okay, the reservoir.
Exactly. Then there's semi-rigid tubing, the space that transmits the pressure.
And something to keep it under pressure, right?
A pressure bag squeezing at about 300 millimeters Hg. That's your squeeze or tension.
Wow, then a transducer turns that into a signal for the monitor?
Yep, converts it to an electrical wave, and the catheter itself, like a Swan-Ganz, goes into the heart.
Through which veins?
Often the IJ, internal jugular or subclavian, its tip eventually sits in the pulmonary artery, giving us all these readings.
And you have to zero it?
Absolutely, it's crucial for accuracy. You align it with the phlebostatic axis, which is the fourth intercostal space, mid-clavicular line. It's like setting a baseline.
So it's not just plugging it in, there's a whole calibration process.
Oh yeah, you have to verify the waveform too with the fast flush test to make sure it's not over or underdamped.
Fascinating.
Okay, so we've got all the pieces. Now let's talk about what these numbers actually mean. CVP, PAP, PAWP, what's the deal?
Fantastic question. CVP, or central venous pressure, tells us about the right side of the heart. It's the right-sided preload.
So how much blood is coming back?
Exactly. Normal range is 2 to 8 millimeters of mercury. If it's low, think fluid loss. If it's high, too much fluid or right heart failure.
Got it. And PAP, pulmonary artery pressures?
PAP gives us the pressure in the lungs arteries. If it's high, that indicates pulmonary hypertension.
Which means the right ventricle is working overtime.
Precisely. And then there's PAWP, pulmonary artery wedge pressure. This one's tricky but super important.
Why is that?
Because PAWP is a surrogate for left atrial pressure, basically telling us about left heart preload.
So if it's high, that's a left-sided heart problem.
Bingo. Over 15 millimeters of mercury usually means left ventricular failure or mitral valve issues. It ties everything together.
So after all that, let's talk about arterial pressure monitoring. Where do we even put these lines?
Radial is most common, but we can also use brachial, axillary, or even femoral as a last resort.
And what do these waveforms look like?
You get a systolic upstroke, then this cool dicrotic notch.
The dicrotic notch?
Yeah, that's the aortic valve closing, then the diastolic downstroke.
Okay, that's specific. Why do we even use arterial lines instead of just a cuff?
For continuous BP monitoring, especially when titrating meds, for precise MAP, for brain injuries, or during major surgery.
So it's more accurate?
Yes, but there's a bias. The arterial line SBP can read 0 to 20 millimeters of mercury higher than a cuff.
No way, really?
And DBP can be 0 to 10 higher.
Okay, so we've looked at what's going on. Now, how do we actually fix it? With drugs, right?
Exactly. That's where vasopressors and inotropes come in.
Vasopressors are for pressure and inotropes for squeeze, basically.
You got it. Vasopressors like norepinephrine increase SVR, so they raise your blood pressure.
So making the pipes tighter?
Precisely. And inotropes, like dobutamine, boost the heart's contractility.
Making the pump stronger.
Yes, but you have to be careful.
Like not give a vasopressor if the patient's already dry?
Totally. You can't squeeze an empty tank. It can actually cause more harm. You need to fill the tank first.
So fluid first, then drugs.
Often. And it's all about titration. You're constantly adjusting based on CO, BP, urine output, and how the patient looks.
It sounds like a delicate balance.
It absolutely is. You want to improve perfusion without overworking the heart or causing other problems.
So after all that, let's bring it back to basics for a sec. Murmur timing really helps us know what's going on with the valves, right?
Absolutely. It's a quick way to tell if it's stenosis or regurgitation. Think about when the valves should open or close.
Right, so if it's aortic stenosis, that's a systolic murmur because it's trying to open during systole?
Exactly. And regurgitation would be diastolic for the aortic valve.
Got it. And mitral stenosis is a diastolic rumble?
Yes, with an opening snap often. Mitral regurgitation is holosystolic, covering the whole systole.
What about those pulse pressure variations we mentioned? Like for aortic stenosis, it's a narrow pulse pressure?
Spot on. And for aortic regurgitation, you'd see a wide bounding pulse pressure.
That's such a clear clinical pearl. It ties everything together so well.
It really does. These little clues at the bedside can guide your whole diagnostic pathway.
And for mitral valve prolapse, that mid-systolic click is the key?
Yep, followed by a late systolic murmur if regurgitation is present.
So how do we put all this hemodynamic monitoring together? What's the pipe to pump algorithm you mentioned?
Right, it's a practical way to manage things. First, you zero the transducer.
At the phlebostatic axis, right?
Exactly. Then you verify your waveform quality with a fast flush test.
That's the square wave check to make sure it's not over or under damped.
Precisely. After that, you interpret your CVP. Is it low? Give fluid. Is it high? Maybe diuretics.
And that helps with volume status.
Big time. Next, use your PA pressures to see if it's primary or secondary pulmonary hypertension.
So figuring out why the PAP is high.
You got it. And finally, you titrate your vasopressors like norepinephrine to maintain MAP above 65 and watch the cardiac output.
So it's a step-by-step approach to keep everything stable.
Exactly. It brings it all together for clinical decision making.
So rhythm emergencies, that's when things get really wild, right?
Absolutely. It's about stability. Is the patient stable or unstable?
And that determines if you shock them or give meds.
Precisely. VFib or pulseless VTAC, immediate unsynchronized defibrillation, and CPR.
What about unstable AFib?
Synchronize cardioversion right away, especially if their blood pressure is plummeting.
In stable SVT?
Vagal maneuvers first, then adenosine. If that doesn't work, then cardioversion.
So adenosine has a super short half-life.
Yes, 6 seconds. It's really quick to terminate AV node reentry.
In PVCs?
Less than 6 minutes, usually benign. More than that or multifocal, check electrolytes and maybe energy drinks.
Energy drinks?
A big cause of ectopy, actually. It's quite common.
So speaking of rhythm and intervention, what about all these amazing devices we have in cardiology now, like mechanical and bioprosthetic valves?
Oh, that's a huge area. We have mechanical valves for young patients. They're super durable.
But with lifelong warfarin, right?
Yep. And then bioprosthetic valves are for older folks or women who might get pregnant, avoiding that anticoagulation.
That makes sense. And TAVR? Transcatheter aortic valve replacement?
Revolutionary. It's a less invasive option for aortic stenosis, especially for high-risk patients. Durability is promising.
Wow. What about when the heart pump just isn't working at all?
Then we're talking about things like LVADs, left ventricular assist devices, which can be a bridge to transplant.
Like an internal CPR machine?
Kind of, and ECMO for full cardiopulmonary collapse. It's intense short-term support.
And for rhythm issues, we have pacemakers and ICDs, right?
Absolutely. Pacemakers for slow rhythms, ICDs for dangerous fast ones. They can literally shock the heart back into rhythm.
Okay, so we've covered the what and how of devices. What about the pharmacology side of things, the drugs?
Oh, that's huge. We're talking calcium channel blockers, vasopressors, inotropes, and the big one, anticoagulants.
Calcium channel blockers like amlodipine?
Exactly. Dihydropyridines like amlodipine primarily cause vasodilation, lowering SVR.
So they reduce the resistance the heart pumps against?
Yep. And then non-dihydropyridines like verapamil slow heart rate and contractility, acting a bit like beta blockers.
Got it. And vasopressors, they're for blood pressure.
Primarily, norepinephrine, phenylephrine, they boost SVR to increase MAP.
And inotropes like dobutamine?
They increase the heart's squeeze. But for all of these, monitoring is key. You're always titrating to effect.
What about anticoagulants? Warfarin?
Yes, warfarin, lifelong for mechanical valves, but it's teratogenic, so a big no-no in pregnancy.
So pregnant patients get LMWH.
Correct, low molecular weight heparin. Also, watch out for direct 10A inhibitors like apixaban and direct thrombin inhibitors.
Lots to keep track of.
It really is a bridge, navigating risks and benefits.
Okay, shifting gears a bit, let's talk about aortic pathology. What exactly is an aneurysm or a dissection?
So, an aneurysm is essentially a bulge, a weakening in the aortic wall, usually due to degenerative changes. A dissection is a tear.
A tear in the aorta?
Exactly. Blood gets between the layers of the artery wall, creating a false lumen. It's a medical emergency.
Wow, are there different types?
Yes, abdominal aortic aneurysms, or AAA, are common. Thoracic aortic aneurysms, TAA, happen in the chest.
And dissections too.
Yep, type A dissections involve the ascending aorta, super dangerous, needing immediate surgery. Type B are descending.
So for an AAA, when do you intervene?
Typically when it hits 5.5 centimeters. We screen men over 65 for these.
And symptoms, how would someone know they have one?
Often asymptomatic until rupture, which is why screening is important. Dissections, though, present with sudden, severe, tearing chest or back pain.
That sounds incredibly painful.
It is, and a key management strategy for dissection is immediately lowering the heart rate and blood pressure.
First with beta blockers?
Precisely, to reduce the shear stress on that compromised aortic wall.
So after all this, how do we tie it together? Like, what's the big picture for making decisions in cardiac care?
It's an integrated pathway. You always start with hemodynamics. Are they stable? What are the pressures telling us?
Right, so CVP, MAP, those numbers.
Exactly. Then what's the rhythm doing? Is it normal sinus, AFib, VTEC? That dictates so much.
And then listening for valve problems, connecting murmurs to pathology.
Yep, murmur timing and pulse pressure. Narrow for AS, wide for AR. Then you consider devices or surgery.
Mechanical versus biological, TAVR, LVADs, pacemakers.
Then add in pharmacology. What drugs do we need? Vasopressors, inotropes, anticoagulation.
And finally, the definitive repair based on everything.
It's a constant conversation between pressure, flow, rhythm, and valve integrity. You're building a complete picture.
Well, that's a lot to think about.
Yeah, for sure.
You carved the fourfold chambers, a fortress beating time. The atria gather quiet streams, the ventricles refine. You shape the valves like sentinels that open at command. Tricuspid, mitral, aortic arch, pulmonic steady stand. Oh Christ, the heart's creator, who set the rhythm free from this spark to flowing pulse. Your wisdom orders me through every beat and pressure wave. Your fingerprints are shown. The body keeps its cadence by patterns you have sown. You lit the Sinoet tree.
glide like silent boats through capillary streams, delivering the breath of life you whispered into being. Oh Christ, the heart's creator, who set the rhythm free from essay spark to flowing pulse. Your wisdom orders me through every beat and pressure wave. Your fingerprints are shown, the body keeps its cadence by patterns you have sown. You wrote the waves that trace the heart, a script in peaks and lines. The P that marks the age you'll spark, the QRS that times. The T-wave tells of ventricles returning to their rest. A silent sacred setting within the human chest. Oh Christ, the heart's creator, sustainer of my days, the author of each rhythm, receive my humble praise. From oxygen to impulse, from chambers to the beat, your science sings of glory, your artistry